encourage all of you to participate. So what will be the answer to this? Left ventricular failure is characterized by wonderful. Cough with pink frothy sputum, which indicates pulmonary edema. Next question. Right ventricular failure is associated with very good, all of the above. All are features of vena cava congestion. Forward feature of left ventricular failure includes wonderful, pallor. A clinical feature that can be produced by both forward and backward mechanisms. Very good, cyanosis. In left ventricular failure, what is the expected pulse rate? Very good. It's usually high because of the baroreceptor reflex, unless the baroreceptor reflex has been abolished. That can happen if there is a heart block or if there is a beta block or overdose due to some other reason. But otherwise, the pulse rate should be otherwise high. We also discussed about the pathogenesis of different types of heart failure and then discussed about clinical examination. So what is the answer to visible impulse over epigastric area can be due to? Very good. Right ventricular hypertrophy. Visible impulse over left second intercostal space. What is the cause? Remember, the left second intercostal space is actually the pulmonary area. The great vessels cross each other. Yes, the answer is A, pulmonary hypertension. Tapping apex is seen in wonderful mitral stenosis, because tapping apex is nothing but the palpation of the loud first heart sound. Again, then this question basically becomes the same question. Loud first heart sound is a feature of. Next question. Splitting of second heart sound is best heard. Very good. While holding the breath after inspiration. Presence of thrill indicates that the murmur is at least of which grade? Answer is D, grade 4. Absence of thrill is grade 3 and presence of thrill is grade 4. Very good. A murmur of pulmonary stenosis is best heard at the height of. Remember that the pulmonary valve is on the right side of the heart. So if something is originating from the right side of the heart, will it be better heart in inspiration or expiration? Very good. The right side receives more blood during inspiration, so all sounds become more loud. Similarly, the left side receives more blood during expiration, therefore all sounds on the left side become more loud. So the answer is A, inspiration. A high-pitched murmur is best heard with. Very good. Diaphragm. A systolic murmur is heard right after. So just think of the pulse wave and think after which heart sound the systole starts. Very good. First heart sound. The time between first and second heart sound is systole, and the time between second and the next first heart sound is the diastole. So the answer is A, first heart sound. In acute injury or inflammation to the valve, what is the first murmur to appear? I did not explain this answer, but let's see if you can answer this. Okay, I'll explain this answer. Yes, the answer is B, regurgitation. The reason is when inflammation occurs, one of the signs of inflammation is swelling. The valves become swollen and edematous. As the valve becomes heavy due to gravity, it falls apart and cannot close. So the earliest manifestation is failure of the valve to close, and this causes regurgitation of blood. Later on, when inflammation becomes more pronounced and the swelling increases, then the valve orifice narrows down and this leads to stenosis. So the initial feature is always of regurgitation, which is followed by stenosis. So acute injury to a valve will always first cause regurgitation, followed by stenosis if at all. So the answer is B, regurgitation. This is the reason you will see following cardiothoracic surgery or following trauma to the heart, the commonest murmur of trauma that you get is a murmur of regurgitation. For the same reason, the first murmur to appear after acute rheumatic fever or infective endocarditis is a murmur of regurgitation. We discussed that CVS is examined in the form of history, general survey, precordial examination, and systemic survey. And we discussed the importance of general survey in cardiovascular system. We have defined the precordial areas, specifically mentioning that these areas do not represent the surface marking of the valve. They only represent the part where the sound of the valve is best heard. We have outlined the point under inspection, palpation, and auscultation. And today we will start with individual long cases. So our first topic of discussion today will be the diseases of the mitral valve. We will discuss the clinical examination and the long case format of disease of mitral valve. Before we start, let us quickly review what we already know. We'll come back to these questions later. Try this one. What is the commonest cause of mitral stenosis? Okay, so most of you are going for A. Next question. The murmur of mitral stenosis is, so what is the timing of the murmur of mitral stenosis? Okay, we are slightly divided in opinion. We'll see what the right answer might be. Moving on to the next question. Mitral stenosis can dilate. Dilate means enlarge. Mitral stenosis can dilate or enlarge all chambers except which chamber is not dilated by mitral stenosis? That is, which chamber does not undergo hypertrophy? There seems to be a lot of difference of opinion here. Okay. The next question. If a patient with mitral stenosis has no presystolic accentuation of murmur, it may be due to. If a patient with mitral stenosis has no presystolic accentuation of murmur, it may be due to. Due to what? Okay, here also there are a lot of opinion coming in. Next question. A narrow gap between the second heart sound A2 and opening snap represents. Does it represent mild mitral stenosis or does it represent severe mitral stenosis? If the gap is narrow between A2 and opening snap. Okay, next. Persistent pulmonary edema can lead to. So what is the effect of a consistent pulmonary edema? Okay, next question. Commonest cause of chronic mitral regurgitation. What is the commonest cause of chronic mitral regurgitation? Next, murmur of mitral regurgitation is. What is the timing of the murmur of mitral regurgitation? Next, the murmur of mitral regurgitation can radiate to. Where does it radiate or conduct? Okay, next. In mitral regurgitation, the first heart sound is. Fine. So we'll discuss the answers to these questions after we discuss the mitral valve pathologies. So let us start with the discussion first. So while discussing mitral stenosis, it's important to know what is the normal size of the mitral valve orifice. The normal mitral valve orifice area is about 4 to 6 square centimeter. Now, it is not like as soon as it becomes less than 4, we call it mitral stenosis. When the value becomes less than 2.5 square centimeter, we define that as mitral stenosis. These sizes can be wonderfully measured using Doppler echocardiography. Additionally, we can also stage mitral stenosis based on the diameter. The mitral stenosis is said to be mild when the diameter is 1.4 to 2.5 square centimeter. It is said to be moderate when the diameter is between 1 to 1.4 square centimeter. And it is said to be severe when the diameter is less than 1 square centimeter. Some authors mention that gray area, that is between 2.5 to less than 4 centimeter, this is, according to some authors, minimal mitral stenosis, and often it may be asymptomatic. So now the question is, what are the common causes of mitral stenosis? The commonest cause of all valvular heart diseases in India particularly is rheumatic fever, or they are of rheumatic origin. So due to a previous rheumatic fever, rheumatic mitral stenosis or fibrosis of the valve occurs, and that is the most common cause. All other causes are less important than rheumatic etiology. So the less common causes can be congenital mitral stenosis, myocarditis caused by the virus Coxsackie B, autoimmune disorders like SLE, obstruction caused by a tumor like atrial myxoma, paraneoplastic manifestations of carcinoid syndrome, because some of the chemicals released by carcinoid tumor, they cause fibrosis of the mitral valve, and infective endocarditis in the late stage, because we know in the early stage it will cause regurgitation. Later on, when the vegetations grow in size, they can cause obstruction and therefore mitral stenosis. So before we start to discuss about the clinical features, let us briefly discuss the pathophysiology and the hemodynamic changes that occur in mitral stenosis. If we understand this pathophysiology, understanding the clinical feature and the findings of the physical examination will be very easy. So let us start. Whenever we start discussing the pathophysiology of a disease, the best way uh, is to start with the fundamental pathology. The fundamental pathology in mitral stenosis is narrowing of the mitral valve orifice. So we'll start with that. So there is narrowing of mitral valve orifice. The narrowing of the mitral valve orifice definitely therefore causes less blood flow from left atrium to left ventricle. So there is reduced blood flow from left atrium to left ventricle. Now this will cause two types of problem. On one hand, there will be accumulation of blood in the left atrium. On the other hand, there will be less blood going into the left ventricle. So let us address them one by one. So on one hand, there will be accumulation of blood in left atrium. And we know the consequences of this. We have already discussed this under backward features of heart failure also. So if there is accumulation of blood in the left atrium, there will be left atrial dilation. There will be dilation of the left atrium. As there is dilation of the left atrium, this can cause some physical compressive features like esophageal compression, etc. So compression of esophagus or laryngeal nerves can occur, and this happens only in very severe cases. This is probably more common in mitral regurgitation. And this can lead to dysphagia due to esophageal compression and hoarseness due to nerve compression. These are usually very late manifestations. On the other hand, the left atrial dilation, you remember, whenever there is stretching and dilation of atrium, it leads to ectopic focus formation. And formation of multiple ectopic focus lead to the development of what we call atrial fibrillation. Atrial fibrillation, on one hand, causes a rapid pulse rate. Along with an irregularly irregular rhythm. On the other hand, the atrial fibrillation causes stasis of blood because the atrium does not contract. And the stasis of the blood, as you know from Virchow's triad, leads to thrombosis. So there will be thrombosis in the atrium. When this thrombus comes out of the atrium and lodges in some other part of the body, this is called embolism. So there may be systemic embolism. These are the consequences of accumulation of blood in left atrium. The consequences are still not over. Accumulation of blood in the left atrium with consequent left atrial dilation goes on. But when the left atrium is totally full, then this will lead to pulmonary venous congestion. So the backward features are starting. Pulmonary venous congestion will lead to raised pulmonary capillary wedge pressure. That is the pulmonary capillary pressure. And this will lead to pulmonary edema due to transudation. This is where the thing might have stopped. But if the pulmonary edema continues for a long duration, over years, this will develop into pulmonary arterial hypertension. The pulmonary arterial hypertension now means that the resistance in the pulmonary artery is more. So right ventricle faces a pressure overload. So there is more resistance to the right ventricle. Whenever there is volume or pressure overload, of any ventricle, it responds by undergoing hypertrophy. So this causes right ventricular hypertrophy. And all such hypertrophy finally lead to failure because the rate at which the muscle fibers divide, at the same rate blood vessels do not divide. So they become extremely malnourished and in the long run develop right ventricular failure. Now, due to reduced blood flow from left atrium to left ventricle, there is reduced left ventricular cardiac output. And this leads to some forward features because of less blood supply to different organs, like angina, like pallor, like fatigue because muscles don't get oxygen, like oliguria, and these features can develop. Is this basic outline clear to everyone? Let me know first. Does this look logical? Okay. So from here, let us calculate what can be the clinical picture in a patient with mitral stenosis. Of course, all patients will not reach the end stage, but let us see through different stages what can be the different clinical features. I'm writing down the clinical features with red color. So see, as there is, as the patient is developing, say for example, atrial fibrillation. Atrial fibrillation would cause tachycardia with irregular pulse. That itself is a feature you can get in general survey. So rapid pulse rate and irregular rhythm is a feature that you will be getting in the general survey. If the patient presents with pulmonary edema, the chief complaint will be cough with pink frothy sputum. And the sign, that is what you elicit at the bedside, is if you auscultate the base of the chest, you will be getting fine basal crepitations, the sign of pulmonary edema. As the left ventricle undergoes a less forceful kind of contraction, and also you will see later, I'll explain that portion, the first heart sound becomes loud. So the left ventricular features on auscultation will be, and palpation will be, a tapping apex. We will explain the mechanisms later. There will be a loud first heart sound. Because of the abnormal flow of blood through the narrow orifice, there will be a murmur, which is classically, you can easily see blood from left atrium goes to left ventricle during diastole. So the sound will start in diastole. And typically the sound starts from the middle part of the diastole and continues to the end. In the early part, the flow is passive, and that is why much sound is not produced. If you remember the dynamics of ventricular diastole, the first rapid filling phase is due to passive flow of blood from high pressure to low pressure. Then is the slow filling phase, which is the filling of blood passively from high pressure to low pressure. And then there is atrial systole. So atrium actively contracts. And this is the second rapid filling phase, and this causes much more turbulence and a louder sound. This louder sound is called pre-systolic accentuation. So the murmur of mitral stenosis typically is a mid to late diastolic murmur. Sometimes we loosely call it mid diastolic murmur. with the sound becomes greater towards the end. That is because of the active atrial systole. With pre-systolic accentuation, that is increase in the sound just before the systole. I will explain all these things under examination. I will repeat everything. So the murmur starts in the diastole because blood flow occurs in the diastole. And when the atrium actively contracts in the second rapid filling phase, the sound becomes louder because of more rapid flow. Now, end of diastole means beginning of systole. That is why end diastolic is pre-systolic. It means the same thing. This is not same as S4. You can think in a different way, of course. You can think that this murmur is the pre-systolic accentuation is something like S4 combined with the murmur. That is how the sound is increasing. That is one way of looking into it, which is not wrong. Now, you can also understand if the patient develops pulmonary arterial hypertension, then this person will have impulse over pulmonary area, that may be visible impulse or palpable impulse. Also, there may be a loud P2. If there is right ventricular hypertrophy, there may be lowered left parasternal impulse or heave. And in very severe cases, there can also be epigastric impulse. If there are right ventricular failure features, then you get classical features like engorged neck vein, pedal edema, hepatosplenomegaly, and in severe cases, ascites. Along with that, the forward features of low cardiac output will be present, but we cannot actually call it left ventricular failure because the end diastolic volume was less to begin with. So the definition that the venous return is normal is not actually valid here because left ventricle is receiving less blood. So we classically cannot call it heart failure, but we can definitely call it an insufficiency of cardiac output. Those patients who have a huge left atrium will additionally have the features like dysphagia and hoarseness. If atrial fibrillation is present, then atrium does not contract. So in presence of atrial fibrillation, one very important thing happens. If there is atrial fibrillation, atrium does not contract, so the presystolic accentuation does not happen because presystolic accentuation is because of the active contraction of the atrium. So you get a mid to late diastolic murmur, but without a presystolic accentuation if the patient already has atrial fibrillation. And if atrial fibrillation is present, it can be easily diagnosed by an ECG. So are these points clear to everyone? Is this absolutely clear? So then I will go into the format of the long case. Okay. So you can understand patient can present at various stages of the disease and not everyone will develop all the complications. So let us create a case. Let us think that we are dealing with a valvular mitral stenosis of rheumatic etiology in a 19-year-old male. Let us assume that the disease has, I will explain the presystolic part. I will explain all the parts that I have explained here. So let us assume that the case we are discussing, in that case, it has progressed to pulmonary hypertension and right ventricular hypertrophy. But till now, right heart failure has not occurred. So there is no right ventricular failure, but only hypertrophy has happened. Now, if you don't treat, it will progress into right heart failure. So that is the stage in which most people will present to you. And let us assume this is that particular case. So let us see how such a case will present to us. You typically start with a history, and patient gives a history of breathlessness and palpitation. You always ask a patient of heart disease, if they complain of palpitation, do you have palpitation at rest or do you have palpitation when you work? Palpitation while working is normal. So it's actually more common in cardiac disease. But palpitation at rest means there is a cardiac arrhythmia, probably atrial fibrillation. In the history of present illness, start from the time when the patient was apparently normal. So the patient was apparently symptom-free 2 years back. Both the symptoms appeared simultaneously 2 years back. The onset was gradual and the symptoms were progressive. And then you always mention the times. He visited the hospital for the symptoms on such and such date and was admitted on such and such date. And there has been no appreciable change in the condition after hospitalization. This typically happens if the patient has a tight mitral stenosis. The only way you can change the symptom is after surgery. Now, breathlessness, as you know, can be due to cardiac reason, can be due to pulmonary reason, can be due to uremic pericarditis, can be psychological. So you have to differentiate and you have to establish that I'm talking about a cardiac breathlessness. So you inquire and then summarize. The breathlessness has the following features. It is precipitated by exertion, relieved promptly by rest, grade 3 or 4 in severity according to NYHA scale, no nocturnal awakening. You are ruling out the PND part, paroxysmal nocturnal dyspnea. No wheeze. You are ruling out bronchial asthma and COPD. No seasonal variation. You are again ruling out asthma. The palpitation has the following features. It is precipitated by exertion, relieved by rest. That means this is probably not atrial fibrillation. If it is atrial fibrillation, palpitation is present even at rest. Then comes the negative history part. You have to ask leading questions to get negative history. In negative history, you don't just ask routine questions. The purpose of negative history is to rule out the other possibilities. There is no history of prolonged cough, blood spitting or hoarseness. You are ruling out tuberculosis and upper respiratory tract infection. There is no history of difficulty in swallowing. So probably giant left atrium is not present. Probably. There is no history of chest pain, blackout. These are features not only of ischemic heart disease, you will see later on, they are also features of aortic stenosis and regurgitation. So you are ruling them out. There is no history of pedal swelling. You have ruled out right ventricular failure. There is no known kidney disease or urinary problem. You are ruling out uremic pericarditis or edema due to a kidney disease. There is no known blood disease or history of blood transfusion. So blood disease and history of blood transfusion, these are routine questions you ask for the risk of HIV and hepatitis B. They also indicate that the patient did not have severe anemia, which could have caused this. Blackout means fainting. So you have ruled out the different complications and systemic causes of breathlessness. Now you take more history. There is no recent history of prolonged fever, joint pain, or hospitalization. That means this is not an acute rheumatic fever. Most often, you remember, complications of rheumatic fever happen 10 to 15 years after it. That is called rheumatic heart disease. So many patients will not even remember that they had similar episode in the childhood. And some can remember, those who have taken the penicillin prophylaxis can tell you that I used to take injection for a long time. But if it is a recent history, then it might be more likely to be a regurgitation because it's acute injury. If it is a past history, then there is a possibility that you are dealing with stenosis. Currently, his breathlessness persists, sleep is slightly disturbed, bladder and bowel functions are regular, appetite is slightly reduced. Whenever there is breathlessness, sleep and appetite normally decreases. When you take the history of past illness, do not just write anything and everything that the patient says. Arrange in a manner that you can deduce the thing. So the patient had an episode of sore throat 10 years back, which was followed by joint pain that was migratory in nature and was dramatically relieved by drugs. After that, the patient had no problem in the joints. Is my screen visible to everyone?
Yes, sir.
Please write yes or no. Okay, so if someone is not being able to access the screen, you re-log in. That is the best way. In the family history, there is no similar illness, so probably we are not dealing with a genetic predisposed disease. In a personal history, now there is a lot of controversy about what you write in personal history. Many people mention sleep, appetite, bladder, bowel in personal history. But personally, I think when you talk about personal history, you talk about the personal attributes of the person that determine the kind of therapy that is socially and economically applicable to that person. So the patient has received education till class 8, works in a grocery shop, he is unmarried and lives with his parents and elder brother. His monthly income is 2500 rupees. At this point, you might wonder what is the need of knowing this? This tells you a lot of things. The kind of language in which you explain the person depends on the education. The kind of family support and social support the person has depends on the social hierarchy. The persons that the person lives with also determines whether they are too old to take care of him or too young to take care of him. And the income also dictates whether a valve replacement surgery will be possible or not. So these are very important parts of history that determine the outcome of the patient. In female, do not forget to take the menstrual history. In the treatment history, you discuss about the present drugs, history of any prolonged treatment, or history of cardiothoracic surgery. Take history of allergy and immunization whenever applicable. Now you come to the general survey. You are more or less sure from history that this is a cardiac problem and probably a rheumatic problem. But you are not quite sure which valve is damaged and what is the extent of the disease. So as before, let us try to understand what this particular patient might have as findings in the general survey. Patient is alert, conscious, cooperative. The faces, you will obviously write whatever you get. So the faces, if the patient is not currently in a failure state, you may get a normal faces. There is nothing specific. You may get a wasted faces if the patient is malnourished. Or you may also get a so-called mitral faces. It is a malnourished face with flushing. Flushing means the face looks more red. That is simply because of venous congestion of blood which cannot return, there may be flushing of the face. But that typically starts happening after right ventricular failure. This person does not have a right ventricular failure. So probably you will get a normal or wasted faces. Decubitus, if the patient is not breathless right at that point of time, it will be off choice. But if the patient is very breathless, then the decubitus may be propped up. Build and nutrition, you write whatever you get because you cannot calculate things here. Pallor may be present, not only because of the anemia, but because you know that in mitral stenosis, less blood is going to left atrium, left ventricle. So skin is receiving less blood. So there may be pallor. Cyanosis again may be present. And again here, it can be due to reduced blood flow to the skin. It can also be due to the pulmonary edema. Icterus, there is no question of getting this, so probably absent. Clubbing, whatever you get, you write. It may be present. If it is present, it indicates a long-standing disease. When you talk about edema in general survey, you talk about pedal edema. This is typically absent because in the description I said we are dealing with a case with right ventricular hypertrophy but no right ventricular failure. Had it been a case of right ventricular failure, then edema would have been present. Neck vein is not engorged. That is because there is no right ventricular failure. Neck glands, you write whatever you find. Pulse, BP, you write whatever you get. Respiration and temperature, you write whatever you get. So this is the typical kind of finding you are going to get in a patient with mitral stenosis. This was important because at least from the general survey, you know that the patient does not have right ventricular failure because you did not get engorged neck vein, you did not get pedal edema. So you know that I'm dealing with a rheumatic valvular disease without right heart failure. So let's see where it takes us. Now you start the precordial examination. So the precordial examination typically starts with inspection. Let the page load. Yeah. So talking about deformity. So do you think this person who developed the disease at around 17 to 19 years age will have chest deformity due to a heart disease? You can just write yes or no. The answer is no, because typically deformity occurs before ossification of the bones, and this typically indicates a pediatric age group disease. At an adult age, that is adolescence and late adulthood, we do not get chest deformity if there is a non-traumatic heart disease. So no, there will be no deformity. So chest will look normal. Scar totally depends on whether there was previous surgery. Venous prominence. Do you think venous prominence over the chest can be found? The veins of the chest drain into the superior vena cava. So do you think in this patient there is superior vena cava congestion? No, because there is no right heart failure by definition. So venous prominence is unlikely. But if you get venous prominence, you have to look for other causes. There are more simple causes of venous prominence other than right heart failure. Some people normally have more superficial veins. That then the patient will say that this is present from childhood. It is not something new that has happened. Some people who work out, they have prominent veins. So if you get venous prominence, it may not always indicate a pathology. It can also be a normal vein. Okay, you were asking if the child had the disease, if he had rheumatic in childhood, might have the disease. Totally depends on the it totally depends on the compensatory mechanisms that happened. If during childhood the disease was mitral stenosis, then probably there will be no chest deformity because you understand in mitral stenosis there is no left ventricular hypertrophy. But had it been a mitral regurgitation where left ventricular hypertrophy occurs, it will push the chest forward. So chest deformity can happen, of course. Now coming to the visible pulsation, we have described the case. So it is a case with right ventricular hypertrophy, pulmonary hypertension, but no right heart failure. So do you think we can get epigastric pulsation? Is it possible? In a patient with right ventricular hypertrophy, is it possible to get epigastric pulsation? Yes, it is not mandatory, but it may be present. So epigastric pulsation may be present. Suprasternal pulsation, you know, it indicates aneurysm of aorta. So of course it is absent. Do you think we can get lowered left parasternal impulse here? Yes. What is the reason that we should get it? Very good. Due to right ventricular hypertrophy. Will you get visible pulsation over mitral area? That is apex. The cause of impulse over mitral area is left ventricular hypertrophy. So did we find left ventricular hypertrophy in mitral stenosis? No. because blood was not entering the left ventricle. So how can it undergo hypertrophy? Which means there will be no impulse over the mitral area. Aortic area. There is no aortic pathology like aneurysm, so there will be no impulse over aortic area. Now pulmonary area. This patient has pulmonary hypertension. So will you get impulse over pulmonary area? Yes. So we may get an impulse over the pulmonary area. Interscapular impulse is not applicable here. It's found in aneurysm of descending aorta. So we may get epigastric, lower left parasternal and pulmonary area impulses. These are the possibilities. Is this clear? Then I'll move on to palpation. Okay. So we now come to the palpatory findings. Apex beat. You already know this. So tell me, what will be the character of the apex in mitral stenosis? Tapping. So apex will be tapping in nature, and the site will be probably normal because there is no hypertrophy. Coming to thrill, my take home trick is you don't comment on the thrill first. So you first check the murmur. If the murmur is present, then you confirm whether there is a thrill. If the thrill is present, you write thrill is present, and then you grade the murmur as grade 4. If you don't find the thrill, but you still find the murmur, you say the murmur is grade 3. So always check the thrill and murmur together. There is no need to do them separately. A thrill is discussed as diastolic or systolic, and it is same as that of the murmur. So we have a mid-diastolic murmur of mitral stenosis. In thrill, we do not mention mid or late because the finding is a crude finding. You simply say diastolic or systolic. So what kind of thrill do you expect in a patient with mitral stenosis? Diastolic thrill or systolic thrill? The murmur is mid-diastolic. So what will be the nature of the thrill? Very good. The thrill will be diastolic in nature. Now coming to S1, first heart sound. Will you get a palpable first heart sound? Yes, this is same as the tapping apex. The tapping apex is a palpable first heart sound. This patient has pulmonary hypertension. So do you get a palpable P2? Yes. This patient has right ventricular hypertrophy. So do you get lower left parasternal heave? Again, yes. Now, so far there was no question of aortic pathology. So will there be any thrill or impulse in aortic area? No. So these are the summaries of the palpatory findings that we get in mitral stenosis. Can we move on to auscultation? So in auscultation, we basically will follow this format. So heart rate, you write whatever you get. So let's assume it's something around, say, 80 per minute. Be careful about the rhythm, because if you mention regular, that means you are indirectly saying that there is no atrial fibrillation. And if you are indirectly saying there is no atrial fibrillation, that means you have to mention the murmur has a presystolic accentuation. In a similar manner, if the heart rhythm is irregular, then you are pointing towards atrial fibrillation. And then in the murmur, you must write without presystolic accentuation. I'll explain this point once again. So the heart rate is, suppose in this case, 80 per minute regular. So rhythm is regular. Coming to the heart sounds, you do not comment separately on M1 and TC1 because they can barely be separated. Split of the first heart sound is not heard. So S1 you simply write loud. Coming to S2, that has two components, A2 and P2. So can you tell me what will be the intensity of A2 and P2 here? You already know there is pulmonary hypertension. So which one will be loud? And which one will be normal? Very good. So there will be, the finding will be A2 is normal and P2 is loud. Loud or accentuated? Yes, it's a very good question how to differentiate which one is A2 and which one is P2. Because it is not necessary that always A2 will be followed by P2. There may be abnormalities also. So how do you identify which one is A2 and which one is P2? This is a wonderful question. Now we have seen that when you hear the second heart sound at the height of inspiration, you get a wider splitting. So what you do here is you place the diaphragm of the stethoscope over the pulmonary area, because over the pulmonary area A2, P2 both can be heard properly. So you place it over the pulmonary area. Ask the person to take a deep inspiration and hold. After taking a deep inspiration, the sound that comes first is A2 and the sound that comes next is P2. This is how you differentiate. Now comes the question, in this case there is no reverse splitting, but if there is a reverse splitting where P2 is coming before A2, then how do I assess that? I will answer this question while discussing aortic stenosis and regurgitation. It's a very good question. This is done by the same maneuver, but the interpretation is different. So till now you know that in case of mitral valve pathology, you simply keep the diaphragm of the stethoscope over the pulmonary area, ask the patient to take a deep breath and hold, place the other thumb over the carotid. The sound that corresponds with the carotid is first heart sound, so ignore that. And then comes two sounds simultaneously. That is the second heart sound. Of the two sounds, the first one is A2 and the second one is P2. This is how you understand A2 and P2. I will discuss about reverse splitting just a few minutes later. I hope this is clear. S3 and S4 are usually not present unless there is left ventricular failure. So here we can simply write absent. Splitting in this case will be probably normal. A slight increase or decrease cannot be differentiated by simple hearing. So splitting will be normal. Now comes a very important finding that is called opening snap. So what exactly is the opening snap? I told you that the commonest cause of mitral stenosis is fibrosis and calcification of the valve due to rheumatic fever. So imagine you have a door and the door is rusted. So when you push that door open, it opens with a snapping sound like nyach. There will be a sound like this. Similarly, when a valve is calcified and due to the pressure gradient it is opening, it opens with a snapping sound, very much like a rusted door. This initial snapping sound or crackling sound with which the valve opens is known as opening snap. So opening snap typically means that the valve can open, but it is partly calcified or fibrosed. Am I clear what is opening snap? And right after the opening of the valve, the blood flow starts and then the murmur will start, because murmur is caused by the flow of blood. So opening snap always precedes the murmur. So opening snap here will be present provided it's a rheumatic etiology. Opening snap also indicates that it is an organic valve disease, not a functional valve disease. Functional means the valve is normal, but more blood is flowing. Organic means the valve is abnormal. If the valve is abnormal, opening snap must be present. Then comes the ejection click. Ejection click is applicable to aortic valve diseases, not mitral valve diseases. So ejection click is absent. Under aortic valve diseases, I will explain what is ejection claim. Coming to the murmur, we know murmur should always be described in these 9 points. So what is the site in which the murmur of mitral stenosis is heard best? That is the apex or the mitral area. What is the timing of the murmur? It is mid to late diastolic. What is the position of the patient? The position of the patient will be stooped forward or left lateral. That is the position in which the mitral valve comes closest to the heart, and so the sound becomes very prominent. The intensity of the murmur will be grade 3 or 4 depending on presence or absence of the thrill. It is a low pitch murmur, a rumbling murmur. So it is a low pitch or hustling murmur, and the quality is typically described as rumbling of the clouds. Because it is low pitched, it is better heard with the bell. And because it is a left-sided murmur, it will be heard better on expiration. This murmur is not transmitted to any part of the chest other than the mitral area, so there is no conduction or radiation. As there is no pericarditis, pericardial valve will be absent. So is this clear to everyone? So when someone in the Viva asks you, describe the murmur of mitral stenosis, or for that matter any other murmur, don't just say a mid-diastolic rumbling murmur. That is not how you describe a murmur. Mention all the 9 points, may not be in the same order, but mention all these 9 points, and that characterizes a classical murmur. So is this clear to everyone? Can I move on? So after auscultation, it's important now to reach a diagnosis. So from the history, general survey, and the physical examination, we can understand that we are dealing with a patient who has a valvular mitral stenosis, probably of rheumatic etiology because of the history of sore throat and joint pain before. And the patient currently has features of right ventricular hypertrophy, but no right ventricular failure at present. For investigation, if you do a chest X-ray, you typically get a chest X-ray like this. An interesting feature of the chest X-ray in mitral stenosis is that the left border of the heart appears to become like a straight line. So the left border of the heart becomes almost like a straight line. This is called straightening of the left border of the heart. So how does this happen? The proposed mechanism is, normally the left border of the heart is like this. Now, what happens here in mitral stenosis is, if I draw another line to show the straight border, so if you remember the standard landmarks on the chest that I had discussed previously, this is the aortic knuckle produced by the aorta. This is the pulmonary bay or pulmonary artery area, along with a small part of the left atrium. And this bulged portion is the left ventricle. Now, look into this very carefully. What happens in mitral stenosis? Left ventricle is receiving less blood. As it is receiving less blood, so size of the left ventricle decreases. So this curved line goes inward, making the line more flat. Blood accumulates in the pulmonary vein, therefore in the pulmonary vasculature and left atrium. So mainly it is the left atrium that goes out. Aorta receives less blood because left ventricle is receiving less blood. So aorta line also goes in. So which means the lines that were present outside goes inside and the lines that were inside bulges outside, making the border almost a straight line. And this has been described as straightening of the left border of heart. Because this is so classically seen in mitral stenosis, this is also called mitralization of the heart. The other features will include if there is heart failure or if there is pulmonary edema, you will get prominent prominences, as you can see, lines. So they are some of the findings that you can get. But most importantly, they are determining of the order of the heart, which is called mitralization. If you do an echocardiography, depending on mitral stenosis, you will get some finding here because it cannot be taught in this way. I'm just showing you a picture for your interest. So this is a GIF image of echocardiography. You can see here carefully the mitral valve that is present above, that is not significantly opening up. It's opening only slightly. And this is the kind of picture that you will get in an echocardiogram. So what are the common questions that can be asked to you in the FIFA after you present the case? So the teacher might ask you, why do you say this is mitral stenosis? So whenever someone asks you the reason behind your diagnosis, your answer should totally focus on summary of the findings. So you will say, I think this is mitral stenosis because inspectory findings of precordium were unremarkable, means there was nothing. Palpation revealed a tapping apex. Auscultation revealed a loud first heart sound and a mid-diastolic rumbling murmur at the apex. All these findings are consistent with mitral stenosis. So I'm repeating the answer. You are basically summarizing your most important findings that support MS. You will say, because on examination of the precordium, inspectory findings were unremarkable. Palpatory findings showed a tapping apex. Auscultation showed a loud first heart sound and a mid-diastolic rumbling murmur at the apex or at the mitral area. So with presystolic accentuation. So I think this is a case of mitral stenosis. So you essentially summarize your key points. That's how you say. Then the teacher might ask you, why do you say it is a valvular mitral stenosis? Who can answer this? Out of all the finding, which one points to the fact that it is valvular or organic, not functional? Very good. Your answer will be because of the presence of opening snap. So because of the presence of opening snap, I call it a valvular or organic mitral stenosis. Then the next question will be, why do you say rheumatic? You can answer it in two ways. If the patient has already told you that I have suffered from such and such disease, or I have taken injection for so long every 3 weeks, you can always quote the history and say, so I suspect there has been a rheumatic fever. But unfortunately, many patients will forget and they will not tell you anything. So in that case, you will say that, sir, this is the most common etiology in India. So unless otherwise proven, I will think of it as rheumatic. Then the teacher might ask you, why do you say there is pulmonary hypertension or pulmonary arterial hypertension? So what will you say? Can someone summarize the points? Why do you say there is pulmonary arterial hypertension? Points in favor of that. Starting with inspection, palpation, auscultation. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52, 53, 54, 55, 56, 57, 58, 59, 60, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70, 71, 72, 73, 74, 75, 76, 77, 78, 79, 80, 81, 82, 83, 84, 85, 86, 87, 88, 89, 90, 91, 92, 93, 94, 95, 96, 97, 98, 99, 100, 101, 102, 103, 104, 105, 106, 107, 108, 109, 110, 111, 112, 113, 114, 115, 116, 117, 118, 119 You will say on inspection, there was an impulse over the pulmonary area. On palpation, there is palpable P2. And on auscultation, there is a loud P2. Not epigastric pulsation. See, right ventricular hypertrophy does not indicate there is pulmonary hypertension. A patient may have a different kind of disease that is causing the right ventricular hypertrophy. So it does not necessarily mean that right ventricular hypertrophy is only due to pulmonary hypertension. So features of pulmonary hypertension cannot be justified by right ventricular hypertrophy. I can argue that this patient has a bivalvular pathology, mitral stenosis along with tricuspid stenosis, or mitral stenosis with pulmonary stenosis. So that does not mean there is pulmonary hypertension, but there will be right ventricular hypertrophy. So that is why you always give the findings. Never assume that one thing is because of the other thing. Also, ECG cannot prove hypertension. Hypertension is a pressure finding. It's a mechanical finding. So the findings should be mechanical. So only the electrical findings can be substantiated by electrical finding. And also, we did not do the ECG here. So we cannot comment on the ECG finding at the bedside. So your answer will be simply based on visible impulse over pulmonary area, palpable P2, and a loud P2. These are the sufficient findings for pulmonary hypertension. Next, we come to why do you say there is right ventricular hypertrophy? What will be the points in favor of that? Yes, epigastric and lower left parasternal impulse. On palpation, lower left parasternal heave. And the apex beat may be shifted outward, not downward, only outward. Apex beat may be shifted outward. These are the only findings that suggest there is right ventricular hypertrophy. Very good. So one question has come up. What will be the finding of functional MS? In functional MS, the murmur will be exactly same as that of the murmur of organic MS. Only opening snap will be absent. So by the absence of the opening snap, you can say it is functional in nature. Now coming to the complications of mitral stenosis, as in any disease, the complications include the features that we already have, like atrial fibrillation, chance of systemic embolism, right ventricular failure, etc. And the complication of any rheumatic heart disease is another attack of rheumatic heart disease, rheumatic fever, or infective endocarditis. So these are the complications of mitral stenosis. So is this clear to everyone? Can you now confidently present mitral stenosis in the examination? Fine. So this was the first chapter, so it took so long. The next chapters will be much easier. We'll build on these previous concepts. So let us start with the discussion of the second mitral valve pathology, mitral regurgitation. Mitral regurgitation can develop suddenly by acute inflammation of the valve, or it can develop slowly due to rheumatic fibrosis. So it can be acute or